Well, good morning and good afternoon, everyone, depending what part of the country you're in. I want to welcome you to our webinar today, Maximizing Medicare Revenue Through Payment Models. Can we go to the next slide, please? My name's Alan Miller. I'll be your host today, and I'm very proud to have with me some very esteemed colleagues who are going to be speaking to you today about Medicare and sharing some of their knowledge. We have Yomi Ajao, who is Principal and Chief Consulting Officer at Cope Health Solutions and the President of Analytics for Risk Contracting, our analytics platform. Dr. Richard Park, who is a co-founder and managing partner of Ascend, which is a very large equity fund, and also founder and CEO of Care About and Render Care, which are MSO and physician organizations. So very appreciative to have Dr. Park here with us. And then we have Bill Weing, the president of Adventist Health, which is one of the larger health systems in the country, a regional system in California, Oregon, and Hawaii. So really pleased to have Yomi, Dr. Park, and Bill with us today. I think you all are going to enjoy the webinar. I'm just going to spend a couple of moments on housekeeping, and then we'll kick it off. So we go to the next slide, please. So just a little bit on housekeeping. During the webinar, you're more than welcome to submit questions, and you can submit them through the Q&A feature in Zoom. You also can just email us anytime, info@copehealthsolutions.com, and we'll be picking those questions up, and we'll either ask them at the end of the webinar, or if we run out of time, we'll take all the questions that come in. We'll provide a Q&A sheet with the questions and answers, and we'll be sending it out to you after the webinar, along with a PDF of this deck, and also a tape of the webinar itself. We'll also be sending you out a brief survey, and if you could fill that out for us, we'd really appreciate the feedback. Next slide, please. So a brief overview of what we're going to cover today. We're going to talk about the Medicare landscape, which has been changing rapidly. A lot of exciting things happening with Medicare in a country, of course, with a rapidly aging population. How do you approach Medicare from a health system perspective, a provider group perspective, and then really talking overall about Medicare and physician alignment and some of the critical success factors, some brief key takeaways, and then again, we'll either have time for Q&A on the call, or at the very least, we'll send Q&A out to folks. So without further ado, let's kick it off. Can we go to the next slide, please? And the next slide. So what's happening with Medicare today? It really is, again, it's Medicare's time in our society. So it's the fastest growing line of business, and Medicare Advantage is growing at an even faster rate, of course, as a portion of Medicare. And then the folks that aren't in Medicare Advantage, there's a very rapid movement of Medicare fee-for-service traditional beneficiaries being aligned into Medicare Direct Contracting entities, ACOs, and other risk models. So the net result is that Medicare Advantage growing faster as a component than Medicare fee-for-service beneficiaries, traditional Medicare, if you will, while at the same time the traditional Medicare beneficiaries are rapidly being aligned into their own risk arrangements. So it's definitely a time of increased accountability, increased access to premium for providers, and different types of financial incentives for plans. The new entrants are noticing. So we're seeing a lot of venture capital and private equity coming into the market. We're also seeing different parts of the healthcare market sector expand their footprints. So a great example would be the Walgreens VillageMD clinic growth plan, where they plan to have many, many hundreds of clinics with pharmacy now and primary care and other types of services. We have folks that have not been in risk moving into risk. So what we're seeing is a sector that used to be highly fragmented, and honestly in many communities still is, but we're seeing that fragmentation now leading to various components of the system expanding out into other areas. So we have payers, of course, for years have been acquiring providers and growing their provider footprints. We're seeing that accelerate. We're also seeing more and more health systems either consider or launch or kind of dust off their own health plans, and Medicare Advantage health plans in particular. And we're seeing a lot of new Medicare Advantage plans launching. We also fully expect to see more direct contracting entities and more ACOs. as CMS and CMMI continue to push that and folks get more interested in the area. Next slide, please. So, one of the things about Medicare, of course, is that it's not a monolithic population. So we're also seeing a lot of work around the edges with different types of populations. And we're seeing major shifts in how Medicare and also Medicare and Medicaid coordinated benefit plans are operating. So for instance, in many states now, they're requiring that Medicaid managed care plans have DSNPs. Certainly in California, that's a very big push right now. You're seeing other states have movement towards saying, look, if you want to be a Medicaid managed care, you need to have a DSNP. There's more and more coordinated benefits across Medicare and Medicaid plans launching nationally, whether it's a DSNP, a CSNP, PACE also, of course, as a program for dual eligibles. We're just seeing a lot of growth in these areas, which you would expect with a rapidly aging population. But I think it's also because people are starting to understand the business models of these things. And so, again, we're seeing private equity and venture capital flow in. We're seeing participants in the industry who may not have been as excited about these before now understanding the value of having people in these different products and how to be able to be successful in managing those folks, both financially and also in terms of improving patient access and care. The other thing that happened recently that's important to keep in mind is the ability for ESRD Medicare beneficiaries to join MA. So that's a big change for Medicare Advantage plans, of course. And overall, one of the things we're seeing and having folks begin to think about is because there has been so much, I call it slicing happening, so many different models coming out of CMMI, so many different companies that have sprung up to go to a health plan and say, I'll take care of this slice of your business. So between the CMMI slice programs focused on a specific condition, such as ESRD, and the various companies springing up going to health plans saying, let us take these sick people off your hands. In a lot of ways, it's an opportunity for health plans and for providers at risk to say to themselves, do I really want to give away these slices, or do I want to get good at doing that myself? So it's one of those choices now for folks to think about, how do you want to deal with those special populations? You want to build programs for them under an overarching risk framework, or do you want to treat them separately and have somebody else maybe manage them for you? So a lot of opportunity movement there. Next slide, please. So the other thing that's been nice recently is CMMI and CMS have really given us a lot of guidance on where they're going. So the recent vision that came out helping us understand that, again, and we've said this on previous webinars and at previous functions we've had with folks, the good news is that there's a pretty consistent direction toward more accountability. And in Medicare in particular, what we're seeing is that there is a movement from the federal government that's very consistent to get beneficiaries linked to and physicians and other providers contracted in accountable care models that better align financial incentives. So if there was doubt as to whether that would continue, I think that doubt has been resolved. It's clearly a consistent issue in CMS and CMMI, irrespective of the administration in place year to year. The other thing that's really important to note, I think, is that some of the things we've been seeing nationally, some of the states have been leaders in this through some of the Medicaid waivers. We're starting to see an understanding from CMS and a requirement from CMS that, hey, not only do we want you providers to be in accountable care models and have aligned financial incentives, we also need you to think about what are you doing outside of traditional healthcare to improve health equity, from an access perspective, from a health perspective, and really close social determinant gaps. So in other words, are you thinking about whether your patient's able to get food or your attributed member is able to get food? Do they have the transportation they need to get to access the right level of care versus just the ER? And so a lot of work around that. Some folks who've been at risk have been doing that for years, buying air conditioners for seniors who need it because they were in risk and understood. Now I think it's become more widespread, and there's a real opportunity for folks to think about their members that are attributed to them more holistically, because you've got the accountable care model and the financial incentives to help you do that. At the same time, again, this is not new for everyone, but this real focus on affordability. So in addition to looking at total cost of care, financial incentive alignment, improving equity and access, and social determinant gap closure, is this affordable for the member, for the beneficiary, which is important. We all just saw that potentially some of the Medicare premium paid by the member would go up And so that focus on affordability in terms of what the member is paying is a very important piece for CMS and CMMI. And then finally, as part of a way to achieve all this, we talked about different sectors of healthcare expanding their footprints, obviously pharmacies and retail getting into clinics and risk, and health plans getting into physician offices. The other thing that needs to happen is how do you then get quote unquote community-based organizations or community-based care services that are not traditional medical care integrated, whether they get integrated into the doctor's office or federally qualified health centers or other sites, or you contract with the local food delivery service, for homebound seniors. So we're definitely seeing a desire to make that happen. So I'm going to ask that we go to the next slide, and I'm going to introduce Bill Wing.
Thank you, Alan. And it's great to be with each of you this morning or this afternoon, whichever the case may be. A little bit about Adventist Health. We'll go to the next slide, please. Adventist Health is a faith-based organization really positioned on the West Coast, representing California, Oregon, Hawaii, and a little bit of Washington. A lot of numbers on this slide. I'd probably just call attention to a few. First, I have the privilege to work alongside 37,000 physicians and nurses, allied health professional, and support services, making an impact across the 75 communities that we serve. And when we think about the 75 communities, that represents about 10 million population. And, a couple things that are unique, I think, to Adventist Health. One is the diversity of the geography that we serve. When I think about the 10 million and the 75 communities, 60% of our footprint is rural or sole provider. And as we think about that, and you're providing nearly 100% of the care in that community, we're operating in a broken fee-for-service model. And so as we think about value-based and the journey to risk, we believe that in 60% of our footprint, we're already there, and we really need to do things differently. What I would also call out on this page is we have the opportunity to touch through visits about 4.5 million of those. But what's more unique is that represents 2 million unique individuals annually. And as we think about our diversity of our footprint and who we serve, it is a disproportionate share of underserved and frail elderly. And when we look at kind of our payer mix across the enterprise, we're 80% government-based, either Medicare or Medicaid. And it's pretty equal. Half of it, 40% is Medicare. The other half is Medicaid. And I would say half of the Medicare we serve are special needs and fall into the dual eligible category. Next slide, please. So as Adventist Health thinks about the future, we've actually organized the company into 3 divisions. The first is our care division, which is really focused on the delivery of care, that 4.5 million visits, 2 million unique individuals. And over the next decade, we want to double the number of individuals served. So how do we go from 2 million to 4 million unique individuals? The second way we've organized is through what we're calling our health division. And our health division is our journey to value-based and at-risk relationships. And when we think about the 4 million unique individuals that we want to serve, this begins to lay out both from our purpose, vision, and what we call big swings, where Adventist Health is focused. And I won't read the purpose and vision. I will move over to the big swings. And as we think about the 4 million individuals, we would like to have 1.5 million of those to be value-based. Today, we're at 300,000. So we've got a long journey over the next 3, 5, 10 years to achieve 1.5 million, but that is our aspiration. Second is that will result in about 4 billion in revenue. And as we think about California, we're currently with our network of both ambulatory, acute, and post-acute, we're covering about 20, 21 counties inside of California. Aspiration is to expand that to 32 counties. Talk a little bit about that. Obviously, our goal is to improve both outcomes on the care side, but also on the health with a top quartile aim and a relentless kind of focus around how do we reduce the friction that is in the overall experience for our members by 25 to 50%. Next slide. So as we think about this journey, there are really 5 areas that we're focused on. The first is on membership. And given the kind of geography that we're covering, we believe that we can't do that alone and that we're going to have to partner that. And so as we think about membership in the 32 counties that we want to serve, what this slide begins to break down is one, what's the glide path to that? And then by line of business, Medicaid, Medicare, and commercial, what does that look like? And as we think about the 32 counties, represents about 23.4 million individuals. Almost 61% are enrolled in some form of managed care. And you can see if we think about the Medicare line specifically, it's about 41% penetrated. And our goal over time is to grow our Medicare to about 250,000 and Medicaid to about 1.1 million with the recognition that there is this overlap with the dual eligible category. The second strategy on the next slide is really our focus on building a network across that geography. If we can advance the next slide, please. As we think about California, and you see the blue on the map, that represents our current network. We have 4 networks that are being either run or expanded. We have a risk network, we have a direct to employer network, we've got one focused on Medicare ACO and commercial CIN. I'm gonna go back to the risk network, which is number 1 on this list as it relates to thinking about Medicare Advantage. And our current network's about 2,900 physicians. About 50% of those are tightly aligned with Adventist Health. The other half are independent physicians who are participating in our networks, and about 23 hospitals. But at the bottom of the slide is really our aspiration as we think about expanding from the 20 counties to the 32 counties. We believe that we've got to expand our network on the physician side by about 6,500 physicians for value-based and at risk, and about 75 hospitals to cover that geography. Our third strategy on the next slide is really our focus around what I'll call payer integration and partnership. Next slide. And as part of this, we believe, given again the geography that we are trying to cover, that we can't do this alone. We need to partner, and so we're identifying just a handful of very strategic payer partners where we're actually creating a shared vision, a shared set of outcomes, and ultimately, I believe, a shared P&L, really focused on how do we integrate both the provider and the payer around administration, around clinical, and ultimately around finance, with the goal of how do we actually change both the member and the provider experience, and also impact kind of the social aspects of care. And when you think about especially the high utilizers in the Medicare Advantage population, that top 1 to 5%, 70% of their issues are directly related to care, but 30% are social. And so we believe that we've got to impact the social component, and that's a key aspect of our relationships. You can see the shared outcomes that we are driving towards collectively at the bottom of the slide, a focus around growth. And much like Adventist Health wants to double, we want our payer partners to double in size. We want to create a world-class experience, both for the individual, the member, and the provider. We want a fully integrated, operationally, clinically, and financial relationship in order to take the friction and the waste out of kind of the experience, an eye towards top decile clinical outcomes and quality, a real focus on innovation and value creation, and ultimately, how do we improve not only care, but health and well-being across the enterprise. Next slide, please. As we think about our approach, and I talked a little bit about Adventist Health being organized around care, health, and well-being. We believe there's an integrated set of services and solutions that we wrap the individual, the family, and ultimately the community with. And this is just representative of those kind of services or solutions, and what's really brought to bear from care, health, and well-being. Because as individuals, we kind of go through life, and at certain points in time, we need care. And obviously the very beginning of life and the end of life are probably the highest intensity areas, but in between, we cycle between care and health, and hopefully for everyone, ultimately well-being. And so we believe organizing, delivering a set of services and solutions around the individual, family, and community is the right approach. And then lastly, as we think about our strategy, let's move to the next slide, please. In order to do this effectively, we believe that it requires a set of capabilities. And not only do we have to integrate between payer and provider, but we also got to think about the functional capabilities in order to deliver on the commitment and promise that we're seeking for our members. And this is just illustrative of what those capabilities are. And, I would kind of close this out by saying, as we think about a health systems perspective, our intent is, again, to create wholeness for the individual, for the family, and ultimately the community through an integrated set of services and solutions partnered with payers in order to create value across those that we have the opportunity to serve. And I'm going to turn this over, if we'll go to the next slide, to Dr. Richard Parks, and he's going to talk about this from a provider group perspective, and probably go a little deeper on, how do we begin to create the change necessary, specifically at the physician level. So Dr. Parks.
Thank you, Bill, and hello, everyone. Thank you, Alan and the COPE team, and to everyone attending. Thank you for letting me share. I want to share today our early experiment, our year-and-a-half foray into how mission with investors and finance can combine and work with operators with real-life experience to work in the government Medicare and Medicaid space as a provider. I have two children. I have a 22-year-old and 20-year-old, and both are autistic. Younger one's nonverbal, and a lot of other associated things that go along with it. And certainly not unique to me, but mental health in children and is a common, it's a common challenge for many people living in the States, around the world. But anyway, I would say they're 22 now, but for the first 15 years, we didn't go to a restaurant. We didn't dare take an airplane flight because we would get an awful lot of stares. Our kids would make a lot of noise. It was embarrassing. They were disruptive. When you're 3 years old and you're screaming on the ground, marginally acceptable, but when you're 10, 12, 15, bigger, with your shirt off, screaming, it makes it hard to go out or be part of normal society. So as a result, what happens is you isolate yourself. You don't go on trips. You see your friends less. You don't hang out with your friends that you grew up with neurotypical children, et cetera, et cetera. And what happens is you begin to believe that perhaps this is it. This is how life is, that you don't deserve better, that you don't deserve to go out, that, happiness is outside your reach and that this is your lot in life. Only in the past 5 or 6 years, as our kids start to mature a bit and we got extra help, that we kind of come out of the funk and re-engage and become less antisocial, certainly introverts by nature, me and my wife, but slowly coming out of it and in a way, developing thicker skin and re-engaging with friends and coming out of and re-engaging. And the results of that, if we can go to the next slide. And what we did as a result of that experience, and Insan, my partner, who I've known for almost 30 years since college, has his own story to share. But we started a private equity firm called Ascend Capital. We raised $570 million to invest in vulnerable populations, the poor and the elderly in particular. How do we care for this population? How do we take our experiences, Insan with his financial background, myself as a physician, ER doctor / operator, first-time CEO, founder of CityMD. How do we take all of that, combine the finances with the operational experience and the mission to care for Medicare, Medicaid patients? Next slide, please. And I want to give a case study on a practice that we helped to start, ignite, and help assist in this endeavor. It's called Render. Render is an Asian-focused practice here in the 5 boroughs of New York City. It started about a year ago, officially as a singleton in August of 2020, right in the heart of COVID. It took 17 practices that beforehand were friends, but separate TINs, separate practices, operating for 15 to 20 years in the community. And most of them have never even been in each other's offices, despite having known each other for 20, 30, sometimes 40 years back in med school in China, because they were friends, but still competitors. How do you take this disparate group, 17 practices, 80 providers, 30 some odd locations, and fuse them into a single practice under a single cap table? And that was kind of what we decided to do. And in August, it became a single TIN under single leadership, single practice, single TIN and cap table. So just to translate that, everyone knew that this is no longer my office. This is only 5% my office. And your office is 3% my office. There was a commonality. It became not just friends, not just cousins, became a single family with a single set of rules. Easier said than done, but we were able to accomplish that in August 2020. Our philosophy here is, with greater control results in greater normalization, standardization, leads to better results, higher performance. So up the food chain, unaffiliated physicians have a certain quality score. If you're joined in an IPA, a good IPA will make you better, and therefore better quality scores. If you're a single TIN practice, and there's different flavors of all these, if you're a single practice, but have a kind of a distributed, federated United States sort of model, it'll be higher. And if you're sort of a dictatorship approach, meaning a single command and control authoritarian, you might actually have the best results. So good, better, best. So we took that approach and we applied it to this population. And what you'll see during the heart of COVID, when we set out in September of 2020, again, practices for the first time working with each other, call center operators that had never met, let alone meet in person or work in person, all distributed at home. We started the year at HEDIS metrics for 5,000 patients at 3.15, their version of quality scores. 1 through 5, 5 being the best, 1 being the worst, for those that most of you would know that. And we were determined to predictably, repeatably scale that to improve. And so what ended up happening is that we ended the year at 4.7 during COVID. And just of note, our best performer of amongst the 80 physicians, Dr. Han Bin, he was traditionally 4.5. That was our top performer, on average 4.5, even in a non-COVID year. He ended the year at 4.95. The average score was better than our best, 4.7 versus 4.5. And so we were convinced, hey, this does work. What does that mean? What works? At CityMD, where many of our founding team members came from, we experienced as physicians an unusual circumstance. We were thrust into urgent care when it was rapid growth, from the first site to the 130 sites when I was gone, from the patient number 1. And when I left, it was 2.7 million visits, or 2.8. In 2021, this year, we'll have 6.5 million visits. But that volume in 8-9 years to accomplish that. But more importantly, how do you standardize physician behavior? We were able to normalize and standardize patient wait times, patients per hour, amongst all 700 doctors in a remarkably narrow band of activity. Could that CityMD approach, that basic industrial approach, apply to primary care? It does. In fact, I would say even more powerfully. The fact that we went from 3.15 to 4.7 is an indictment on healthcare. That should not have been possible. This is what our explanation is. And we didn't do anything fancy or particularly groundbreaking. If you can move to the next slide, please. Next slide, please. There we go. Vulnerable populations, at least here in New York, the poor and the elderly, are usually patients of ethnic persuasion who are attracted, birds of a feather, to ethnic physician groups. So you can't do a one-size-fits-all approach. At least for the Asian group, Hispanic group, every group has a group. What we encounter in these physician practices, caring for Medicare, Medicaid, caring for the value-based patients programs that government demands, the very groups where sophistication has to be the best, these are the groups that are the least invested in. I'll give you an example of that. Payer after payer are demanding our physicians, our poor doctors, to coordinate. Well, let me tell you, when we first met these 80 doctors, almost nobody amongst the physicians or the staff had email. Nobody used email. So forget about coordination. You have to get them to use email. We would go into offices and it would not be uncommon to find Windows 95 and Netgear routers that don't talk to each other, no phone systems, everyone calling, no nomenclature of insurance companies, names, patients, no normalization or standardization of anything. You're asking these providers to take risk when they don't have email. It's impossible. And so the Ascend team, we quickly realized that we have to invest in basic infrastructure. I show you this dashboard. This is an embarrassing dashboard to me, actually. It's not sophisticated. I've had much better Domo, Tableau dashboards in the past at CityMD, but just simple carbon paper is all you need to get to 4.7. And it begins with something as simple as everyone having email so you can distribute dashboards, having managers that will go over and teaching your managers how to read a spreadsheet from left to right, top to bottom. You'd be surprised what is not known by the average human being. Value-based plans require the floor of healthcare providers to be raised. You have to invest in basic infrastructure. They don't need your AI. They don't need your business intelligence or data. They need Windows Office first. And we liken this to when you go to a playground and you have major league pitchers throwing 80-mile-per-hour fastballs or curveballs to little children. Of course they can't catch it. They're not ready. And instead of teaching the catcher child skills to catch fastballs, you instead think, if I only throw a faster fastball, surely we'll have better results. I'll throw a 90-mile-per-hour fastball. That's not the problem. The problem is the infrastructure of the providers. And so, especially in the Medicare, Medicaid world, particularly in New York, where it's mostly ethnic. And so again, basic incentives. How do you implement incentives? Through dashboards and through managers. Very simply stated, but really hard to do. If we can move to the next slide, please. Incentives are very powerful. Implementing incentives is very challenging. At CityMD, early on, the first couple of years, my only request for the doctors was that everyone, I want all of you to wear white lab coats, be professional. Now, we had a history, we were all ER doctors, and so our culture is that of parachute pants and scrubs. And you couldn't find us to wear a lab coat or a tie. Forget about a tie, impossible. Lab coat, maybe. But I cajoled, threatened, begged, could not get that accomplished early on. But later on, we were able to accomplish much more complicated things. ER send rates, MPS, weight patients per hour, HEDIS metrics. We were able to implement that much more complicated metrics and able to standardize that later on. Today we know exactly how to get our doctors to wear white coats. The way we would do that is we would tell our doctors, for every hour you wear your white coat, it's $5. Not only that, we're going to get you a dashboard that it's going to be forced into your email. We're going to push it to you. You don't have to even ask for it. And it's going to tell you exactly how many hours you had it on. And it's going to be accurate. If you wore it for 12 hours, it's not going to say 2. Nothing infuriates people more than something like that. And not only that, and this is not unknown to everyone here, at the end of 2 weeks, you're going to get paid. Incentives are very powerful. That's a very simple statement, very simple assignment. Execution is incredibly challenging when you don't have standard accounts, when you don't have email, when you don't have, if we still have Windows 95. And so it's all about investment in the basic infrastructure. More carbon paper, less AI. More basic computers, less artificial intelligence. At least that's our experience here. And that's how our approach to combining the best of operations from ground up by people that have gone through these challenges, where when things don't work, we feel it, it hurts us, and we feel the brunt of it, to the mission of investing in vulnerable populations tied to finances. That's all aligned properly. And it's been a year and a half. Check in with us in another year and a half, and we'll see how we do. Next slide, please. To further that end, Care About is the organization brought about by Ascend that helps write the playbook and the toolkits as a vendor, as a consultant to our practices. This is the care about team that invested in Essen, that invested in Renda, that invested in Consensus, et cetera, across the board. Michael Carson just started with us last week. Michael Carson was a former CEO and president of Harvard Pilgrim as it merged into Tufts Health Plan. Some other notable names: Dr. David Shi, the Chief Medical Officer, MVP thus far, co-founder, one of my co-founders, and the former Chief Medical Officer at CityMD, and basically putting down, instituting basic incentives and implementing it to get to the 4.7. And he's doing it all over again this year with every payer. It's the same approach, same thing, whether it's RAF scores, HEDIS metrics, or lab codes, same approach. Implementing incentives. It has to be under the doctor's control, actionable. It has to be accurately shown, and you have to have immediate compensation. Other names not on this page is Brian Leclerc. Brian Leclerc is an executive board member, but Brian Leclerc was a former CIO of Humana. Spends 2 days plus with us a week. Very instrumental. Dr. Ben Stein, the former CEO and former the founder of Healthix New York, Healthix of New York, and Scott Farnsworth and Mo. All this to say, a lot of this is about data, implementing incentives through proper data and the playbook. We have a few playbooks that the team works on. Playbook number 1 is mergers and acquisitions. How do you get sub 10 physician groups to want to join you? Why would they join you? It's the first playbook. Why would a 40-year-old want to join you? Why would a 60-year-old want to join you? Why would a capitated doctor want to join you versus a commercial? All of these things, that's a playbook for that. And the toolkit to reinforce with numbers why someone should or should not join us. There is the management playbook. How do you manage an IPA? How do you manage a franchise model singleton practice? How do you manage a more centralized version of a singleton practice? And how do you move people on up along that sort of control scale? Incentive playbook. How do you incentivize physicians? How do you incentivize pediatricians versus specialists? In a capitated world, in a commercial world, how do you get the right incentives? Because good incentives are important, but hard to measure and hard to implement. Bad incentives can be destructive. So that's the playbook. For a 40-year-old, a 60-year-old, a partner physician, employed physician, all flavors of. And finally, the data playbook. How do you get dashboards? What does it take to create dashboards for your managers to implement incentives? It takes things, very simply put, Windows 95 to be gone. But more than that, operationally, you have to standardize every piece of data. When we first came in to Render as an example, every office would be on the same EMR, but have different instances. They would all call the different products in United Healthcare, for example, or Health First. They would call these products different names. They would misspell them sometimes they don't differentiate. But we had hundreds of templates. Nobody used or inputted information the same way. Of course, you can't get accurate dashboards. If you don't get accurate dashboards, of course, your doctors are not going to trust information. Of course, you can't pay them properly. It'll just make them angry. So implementing incentives is the lesson that we've learned here. And to implement incentives requires installing flooring, raising the floor, not the ceiling. So with that, I'm going to actually skip the last slide and pass it on next to the next speaker. Thank you for listening.
Thank you, Dr. Park. This is Yomi Ajao, the Chief Consulting Officer within COPE, and it's actually quite good and interesting to listen to both Bill from his Adventist perspective as a large hospital network, and as well as Dr. Park from an IPA working with the provider at the tactical day-to-day level and all the appropriate infrastructures that needs to be put in place to ensure that they excel in everything they do. Next slide, please. So there are some nuts and bolts to managing Medicare programs. Alan went over a series of different type of products that is encompassed in them. There's some broad set of focus and capabilities. Sometimes I call it, it's almost like you are training your muscle that is needed, and in many cases, even beyond Medicare, to other type of risk arrangements that one might want to consider, whether commercial or even Medicaid program. Some of the building blocks that is required is at a high level category level is obviously ensuring that we can manage quality, both at a metric level as well as an outcome level. You can see how impressive the work that the render team has done in terms of being able to improve their quality scores. And many of the initiative that requires is those consistent processes, provider training, in some cases, call center to support them, so on and so forth. So granted that every IPA, every practice has different set of sophistication and in some cases challenges. Being able to get in there and understand what it takes to be able to improve performance is the key essence of being able to do this and do it successfully. The other piece, other area of focus is what I call revenue optimization and growth. From a revenue optimization, and this is actually very particular to Medicare, is ensuring that your members are in the proper products that is most appropriate for them. So whether it's a regular Medicare Advantage product, HMO-like products, or it's a condition-based type of product like CSNP, ISNP, and even duos, ensuring that the members are in there is in many cases a key value point to being ensuring that you're successful, because the goal is to ensure that the revenue matches the expenses that those type of individuals is going to take to manage them. So quite a bit of work to be able to do and quite a bit of muscle to build to ensure that we are doing that and doing that successfully. And last but not the least is managing utilization and in many cases unit cost as well, depending on what levers we have at our disposal. And utilization management is about understanding the population that we have, understanding their behaviors, and deciding where the help is needed the most. How do we triage our care management, our provider network to be able to support them in their ways of using the system, and are there more optimized way of navigating the member/patients through the healthcare process. So that's very key in being able to be successful in managing Medicare programs in particular. Next slide, please. So in continuation, there are multi approaches to understand, embrace, and build those muscles. There are approaches that has to do with just being able to understand contracts, the various type of contracts that might be in front of you. It varies quite a bit. The MSSP versus DCE versus regular Medicare, the nature and scheme of how those contracts are structured is essential in terms of understanding it and ensuring that all the apparatus that is being built is aligned to some certain degree, as well as all the infrastructure that we just talked about to manage utilization and improve quality at the end of the day. So those set of infrastructure is absolutely essential. Documentation is also quite important because that drives quite a bit of value from both ensuring that there's an appropriate risk score or risk coding, as well as being able to reflect the work that is being done on quality, and in many cases also drives product assignment or product allocation in many cases as well. So having those set of tools and ensuring that the provider network understands the value of it, understands how to do it well, and providing the appropriate training and support, those key essence in being able to be successful, and showing that all the good work that is being done is reflected. Next slide, please. Yeah. So, as many of you know, there's that Pareto rule that is extremely exaggerated in healthcare, whereby the top 10%, top 15% consume majority of the resources in healthcare. And how do you focus on them? How do you understand who they are, how they consume, and what can be done to engage them in a productive way that actually helps relieve their outcome and not just add more logistics stress to seeking care. So at a very high level, identify, outreach, intervene, and measure, so we can continuously improve. Next slide, please. Good. Now, I spoke about some broad set of capabilities that we need to have, from a quality improvement, revenue understanding and optimization, as well as utilization management. Those are a set of broad muscles that we need to have to be successful. In addition, there are uniqueness to each of the programs that are out there from a Medicare standpoint. So you got MSSP, Medicare Direct, Medicare Advantage, the SNPs programs. And it's very important that we understand all the levers that's associated with each one of the arrangement types. And even within each and arrangement types, there are multiple flavors of them. So we need those both financial contracts and clinical muscles to be able to understand how that works downstream across the board. A couple of areas that I'll call out is membership attribution. It's different in terms of the different kind of programs that you are part of, or you have within your contract portfolio. Some are voluntary, some are assigned, some are prospective, and some are retrospective in terms of the assignment. And then as well as the risk adjustment methodology has a significant impact into determining value at the end of the day, and in terms of what kind of impact that changes your revenue profile. Next slide, please. And lastly, physician alignment and incentive. I think Dr. Park spoke eloquently about this quite a bit in terms of how do you align your providers so we can all be rolling in the same direction. I won't get into the tactical weeds of it, but is a cornerstone of being successful, because there are many approaches out there There's approaches whereby you want to manage around the providers, or you want to manage through the providers. And I think one of the things that we have seen successful over the years is managing through the providers compared to managing around the providers. So it's a key tenet to being successful in managing those Medicare programs in particular. So I know I'm almost running down on time, so I'll pause on this and kick it back over to Alan Miller for some closeout thoughts.
Thank you, Yomi. Well, first of all, I don't know about the rest of you, but I really feel very lucky and impressed getting to sit and listen to Bill and Dr. Park and Yomi. I always enjoy myself, honestly, getting these kinds of updates from them. And so first I want to really deeply thank Dr. Park and Bill and Yomi for taking the time to do this and for sharing your thoughts. We're close to the hour, and so what I'll say is that I don't think there is a lot left to say that you haven't heard from our three speakers. If there were a few kind of high-level takeaways, you have to have a unified strategy and vision for where you're going to go, and you have to be aligned around that at the leadership level and your doctors, who are also key leaders in what you're doing. You have to provide your doctors with the basics, as Dr. Park talked about, and with accurate, transparent data. So what are the metrics we're focused on getting in that data? And that includes having financial data so they can understand how they're doing. You have to implement governance and processes that engage your physicians and your members in order to be successful. And finally, as Yomi talked about, you have to understand your members. What is their health status? What is their health access like? What kinds of needs do they have outside of core medical needs to be able to close social determinant gaps? So I think there are probably a lot more takeaways. Those are the ones I jotted down. We're at the hour. I want to thank you all so very, very much for attending with us. I hope you all have a wonderful, safe day, and we'll go ahead and close out the webinar.